Welcome to another session in my series Surgery for Undergraduates. And today's topic, we are dealing with chronic pancreatitis, which is a chronic and debilitating disease for the patient and a challenging for the physician treating him. First, the introduction. What is chronic pancreatitis? Chronic pancreatitis is a chronic fibroinflammatory disease of the pancreas. There's a lot of fibrosis, resulting in a progressive and irreversible damage to the pancreatic tissue. So the whole parenchyma becomes lost, and with the resulting loss of the exocrine and endocrine function. The incidence of chronic pancreatitis is quoted between 2 to 10 new cases per 100,000 people in most of the Western countries. It has a male to female ratio of 4:1 and an average age of onset of 40 years. Before we proceed, let's have a look at the anatomy of the pancreas. This pancreas, as you all know, sits in the C-shaped segment of the second and third part of the duodenum. And it is drained by a main pancreatic duct that runs through its body and tail and joins the common bile duct at the ampulla of water to drain into the second part of the duodenum. As you all know, the pancreas consists of exocrine and endocrine portions. The bulk of it is the exocrine, which secretes the digestive enzymes, and the lesser important or lesser volume of tissue known as the islets of pancreatic islets secrete the endocrine hormones of insulin. What's the pathology like in acute pancreatitis? In acute chronic pancreatitis, there is initially the pancreas becomes swollen and bulky due to inflammation, and there is finally becomes into a chronic phase where the ducts become dilated and strictured at intervals. So there is calcification, fibrosis, and stricture dilatation and duct dilatation and strictures. This is what we have at the end of after many years of chronic pancreatitis. The ducts become dilated and strictured. The pancreas becomes atrophied, and the function of the pancreas becomes obliterated. So as a result, the ducts become occluded. There are a lot of inflammatory cysts in the pancreas, stricture and dilated ducts with calcified stones. Enlarged, the pancreas finally becomes enlarged, hard, fibrotic, with loss of exocrine and endocrine functions in the pancreas. So in summary, there's a long-standing inflammation of the pancreas, loss of normal structure of the pancreas, episodes of acute inflammation in a previously injured pancreas may continue, known as the acute or chronic pancreatitis, and chronic damage with persistent pain and malabsorption. So these are the features of chronic pancreatitis. Now, what's the etiology of pancreatitis? The main causes of chronic pancreatitis are twofold. It's either chronic alcohol abuse, which accounts for 60% of patients, and idiopathic in 30% of cases. In the remaining 10% are the lesser or rarer causes of metabolic causes such as hyperlipidemia and hypercalcemia, infection, especially virus, hereditary, examples in cystic fibrosis, where it runs in families, autoimmune pancreatitis, where there is autoimmune pancreatitis going on, or sometimes it occurs in patients with other autoimmune disease such as SLE. Congenital abnormalities are also causes which cause obstruction of the pancreatic duct, such as pancreatic divisum and annular pancreas. What are the clinical presentation of chronic pancreatitis? Recurrent severe episodes of dull pain, epigastric and subcostal region, more on the left side. Pain radiates to the back and to the left shoulder, aggravated by food and especially alcohol, nausea, vomiting, and inability to work are other complaints. And there is progressive weight loss because, and also there is analgesic abuse because of the chronic pain. Patients tend to become dependent on narcotics. There are loose stools, increased fat in the stools, steatorrhea, and malabsorption due to lack of enzymes. This disruption of the endocrine pancreas invariably leads to diabetes mellitus in most cases. So in short, the symptomatology is abdominal pain in 90% of cases. They are episodic and exacerbated by eating food and especially alcohol. In the late phases, these symptoms burn out because of the pancreatic failure, and then there is less pain but more malabsorption. Weight loss, avoidance of meals because of exacerbation of pain, and malabsorption due to deficiency of the digestive enzymes. There's also exocrine insufficiency leading to steatorrhea and malabsorption. Okay, pain is the most common complication or symptom, main predominant symptom of both acute and chronic pancreatitis. But there are some differences. In the pathology, acute pancreatitis, there's neutrophilic infiltrate reaction, whereas in chronic pancreatitis is a mononuclear infiltration and fibrosis. Serological markers like amylase and lipase are highly elevated in acute pancreatitis, but in chronic pancreatitis, they may be within the normal range. Symptom, always acute pancreatitis presents as a painful crisis, acute painful crisis. Whereas in chronic pancreatitis, it is more of a chronic, persistent chronic pain, and parasitic and pancreatic insufficiency are the most common symptoms. Okay, and there can be long periods of asymptomatic intervals, especially as the history of the disease becomes more chronic. What are the differential diagnoses of chronic pancreatitis? These on the left, these are the common ones: acute cholecystitis, acute pancreatitis, intestinal ischemia with infarction, the so-called mesenteric ischemia, obstruction of the common bile duct with jaundice, pancreatic tumors, peptic ulcer disease, and renal insufficiency. Less common differential diagnoses will be acute appendicitis, acute salpingitis, and the list that follows here. Okay, so there are a lot of conditions that chronic pancreatitis may mimic. So it must be carefully investigated to confirm the diagnosis. And a word about chronic pancreatitis and pancreatic cancer. It is very difficult to diagnose clinically, to differentiate between those two. So you may need other techniques, biopsy techniques, tissue diagnosis to differentiate chronic pancreatitis and pancreatic cancer. To understand, chronic pancreatitis can predispose to pancreatic cancer, and pancreatic cancer can also predispose to development of chronic pancreatitis by causing chronic obstruction of the pancreatic ducts. Okay, the investigations for these patients include urine and routine blood tests, including full blood count and the CRP, okay, which will be raised in patients with chronic inflammation of the pancreas. Serum amylase and lipase, which I already mentioned, are often not raised, are not really helpful, but will differentiate it from acute pancreatitis. Blood glucose is an important parameter that must be measured, with HbA1c to rule out endocrine involvement and diabetes mellitus. Liver function tests may have to be done, especially to rule out concurrent obstructive jaundice in these patients. Fecal elastase level will be low in most cases of chronic pancreatitis because this elastase enzyme is produced by the pancreas and excreted into the bowel to aid with digestion. And importantly, it does not undergo any significant degradation. So when you detect a reduced level of diastase in the stool, it will more or less is an indicator that the exocrine function of the pancreas is decreased or minimal. So these are in summary: blood, CRP and blood count, serum amylase and lipase, blood sugar, LFT, stool fecal elastase. Pancreatic function tests also can be done, especially the secretin stimulation test to test for the residual function of the pancreas. Then among the imaging techniques will be X-ray abdomen, which will show calcification in the area of the pancreas. CT scan, which is diagnostic only in the late phases. MRCP may give you a biliary anatomy and duct abdominalitis due to blockage, stone, and stricture. ERCP is very important diagnostic. Not only diagnostic, it is a therapeutic procedure as well. If there are strictures or stones, then stones can be removed and the ducts can be dilated and stented. EOS is becoming an interesting and important investigation which can obtain a fine needle or fine needle biopsy to rule out cancer of the head of the pancreas. Okay, this is an abdominal X-ray which shows plain X-ray, which shows chronic calcification in the region of the pancreas. The clinical history plus this finding of calcification more or less confirms the diagnosis of chronic pancreatitis. Okay, here again is a CT scan showing the slightly enlarged pancreas with duct dilatation and most prominently calcification. Okay, dilated ducts and calcification. Same thing, dilated ducts and calcification. And here, apart from the acute pancreatitis, it also shows an enlarged cyst, which is a pseudocyst in the pancreas. Okay. And ultrasound, I told you, endoscopic ultrasound, US is an important investigation these days, where we have a closer look of the pancreas and the duct. You see, the pancreatic duct is dilated with areas of stricture, narrowing, and multiple stones within it. Here, ERC pancreatogram or ERCP will show strictures and circulations of the pancreatic duct. Okay, these are circulations, rounded sacs. So these, or some people call it chain of legs or beaded experience, beaded appearance, which is diagnostic of acute pancreatitis. This, in this case, is a dilated duct, so it is possible to do dilatation and even bypass procedures if necessary. Management of chronic pancreatitis, analgesia is a main three things. Analgesia, overcome the malabsorption by giving dietary supplements of digestive enzymes, and also treating diabetes. So three things: analgesia, malabsorption, and diabetes. These are the three underlying conditions that must be treated when you treat chronic pancreatitis. The use of steroids is effective in reducing symptoms of chronic pancreatitis, especially so if it is an autoimmune pathology. So chronic inflammation can be helped with steroid to reduce the pain. Usually you start with a high dose followed by a low-dose maintenance regime. Then endoscopic management becoming very important these days because surgical intervention is rarely performed due to high complications, morbidity, and mortality. Okay, and with limited symptomatic improvement. Okay, so surgical intervention is becoming less and less important, and endoscopic management becomes more important these days. Even endoscopy is performed only a selected few patients respond or amenable to such endoscopic management. ERCP can be used for diagnosis, as I said, and also therapeutic purposes, including removal of stone, placement of stent, and sphincterectomy. Okay. Endoscopic or EUS guided celiac plexus blockage can be done to reduce chronic pain in patients who are not responding to opiates. Sometimes splanchnicectomy can be done by thoracoscopy. Okay, is damaging the sympathetic system, which mediates the pain in these patients. Okay, in summary, the treatment consists of control of pain, improved digestion, use of preparations such as crayon, and control diabetes. Interventions are mainly to relieve the obstruction of the pancreatic duct and to treat the complications such as pseudosis, abscess, or ascites that may develop as a result of the chronic inflammation. Okay, again, to remind you, endoscopic pancreatic sphincterectomy, endoscopic placement of stents across stitches, and drainage of pseudosis are all important and useful endoscopic procedures to improve the quality of life in these chronic pancreatitis patients. Surgery is only done to remove the mass lesion or relieve obstruction if it occurs. So the indications for surgery will be pain most of the time. 80 to 90% of the patients with severe pain may need surgery to drain the pancreatic duct by some method. Or presence of a mass, which you are not sure. Suddenly a mass appears or the symptoms become different to suggest malignant change. So you may want to go on to do operation. Biliary and pancreatic obstruction, duodenal obstruction, pseudosis of the pancreas, internal fistula, especially pancreato jejunal and pancreato-intestinal fistula, vascular problems like portal vein and splenic vein thrombosis. So all these may indicate surgery. But again, these days, most of these complications can be relieved to a certain extent by endoscopic procedures. And I say, as surgery is the last resort when everything else fails. Okay, and the procedures that are available is a Whipple's operation of pancreatoduodenectomy. Okay, then Pesto's procedure, which is longitudinal pancreatojejunostomy. Okay, where a loop of jejunum is anastomosed to the dilated pancreatic duct, which is opened up. And of course, the last is the total pancreatectomy, which is removes the whole pancreas. This is a very major operation with a high mortality and there's no guarantee of pain relief. So looking at it, actually there are not much surgical procedures that are really available and that are superior and lower risk than endoscopic procedures. Okay, this is the Pesto procedure, pancreatojejunostomy. Okay, the pancreatic duct is opened out, dilated pancreatic duct, and a loop of jejunum is anastomosed. Okay, so pancreatojejunostomy. This is before the procedure. Okay, normal. And here, after the procedure, the loop of jejunum is side to side anastomosed with the pancreatic duct. Prognosis of chronic pancreatitis is not very good. It's a bit gloomy to know. There's significant morbidity with this disease, reduced quality of life, okay, and challenging condition for manage for the surgeon or the physician, okay. So these are the three important things. It is significant morbidity, reduced quality of life, and challenging condition. In some patients, the disease may eventually burn out after many years of pain, leaving a residual endocrine and exocrine insufficiencies, which are treated medically. Pancreatic malignancy is a risk that chronic pancreatitis may develop, especially long-standing for 20 years or so. So any patient of chronic pancreatitis with new or evolving symptoms should therefore undergo investigations, like a CT scan, MRCP, or US biopsy. So the prognosis generally is poor. Okay, as I tell you, chronic, progressive, and debilitating disease, painful, and no cure. Overall mortality is 30% at 10 years and 55% in 20 years. Risk of pancreatic cancer is 40% at 20 years. Okay, these are all suggestive of very poor prognosis. The prognostic factors are: younger the age, the worse the prognosis; smoking, persistent alcohol continuation; liver cirrhosis; comorbid illness, diabetes, heart failure, or stroke, or some other conditions; and cancer, development of cancer. These are all prognostic factors that determine the prognosis of pancreatitis, chronic pancreatitis. Okay, so this is the bleak natural history of chronic pancreatitis, early pancreatitis and late pancreatitis. Clinical features: acute, early phase is like acute pancreatitis, acute relapsing pancreatitis, or chronic recurrent pain. Late pancreatitis, the pain is chronic and recurrent, associated with pancreatic exocrine insufficiency and pancreatogenic diabetes and secondary pancreatic cancer. These are the clinical features. Diagnostic tests: ultrasound and CT, usually non-diagnostic in the early stages. CT scan is usually diagnostic in the chronic phase. Endoscopic ultrasound becomes important in these cases to diagnose. Okay, here MRI and MRCP are usually diagnostic. Okay, they are just diagnostic but unable to be, it's not therapeutic. Secrete stimulation test is an important phenomenon. Here, fecal elastase is important as a diagnostic factor. Pancreatic function test is important. Here, the pancreatic function test usually will be mostly negative. HbA1c is important for diabetes mellitus. Therapy, here is medical therapy: avoid alcohol and tobacco, analgesics, and nowadays we have the newer ones, carbapentins, which are also quite effective. Over here, most of them have got continued medical therapy for pain. Many of them finally end up with opiates. Endoscopic or surgery therapy for pain if pancreatic duct is dilated. Pancreatic enzyme replacement therapy, vitamin D and calcium, and nutritional assessment and supplementation, and also treatment for diabetes mellitus. So these arrows here in red signify the chronic nature of the disease. Early phase is 3 to 5 years, and the chronic phase 5, 10 years and beyond. Okay, so the patients, the pain, persistent pain over all these years, progressive inflammation of the pancreas, and progressive loss of exocrine and endocrine function of the pancreas leads to generalized delimitation of the patient. So management of chronic pancreatitis, few points, is painful endurance for the patient for years, is challenging for the physician also for years, because most of the time the patient becomes dependent on the physician and the medical facility that provides the treatment. He becomes a regular visitor. In fact, the hospital becomes his second home. The management is more than just giving of pills and surgery. Okay, the management involves a great deal of empathy and understanding of the patient's behavior and symptoms, compassion, some degree of compassion towards him, and also moral support in times of severe pain and crisis with loss of employment and financial losses, and of course, a high level of tolerance for his so-called nuisance at your clinic for many years, many years. So the key points in this discussion is to take home from this lecture is chronic pancreatitis is caused by chronic alcohol excess. So try not to get addicted to alcohol. Most of these patients, because of chronic use, they become dependent on alcohol. Patients present with central abdominal pain and radiating to the back. So usually central abdominal and back pain, along with features of endocrine and exocrine insufficiency. Okay. Reduced fecal elastase and CT imaging can be used to confirm the diagnosis in advanced cases, in late cases. MRCP and ERCP are usually needed and are usually done to identify whether any indication for surgery or whether there is an indication for endoscopic interventions. The management is mainly based around symptoms control, optimizing the analgesia, nutritional support, and also counseling with moral support. Okay, the journey of a chronic pancreatitis patient is hard and challenging. Thank you for joining me with this short session on chronic pancreatitis. I hope this short session will be useful to you. I hope to see you again in another session in the near future. Thank you.